of the work that I've done in specialized custom devices was get detailed imaging of what the airway looks like. And so to do that, I actually put myself in a fine resolution CT scanner. And so here's what it looks like. So you see all this soft tissue, but if we peel away all the soft tissue, this is what we have underneath it. So this was very scary for me to see what my So the gray here is bone, and the yellow is the airway. So we have the voice box here, then we have the throat area here, the tongue up in this area here. So that broad areas, oral cavity, nasal pharynx or nasal throat, oral pharynx, oral throat, supraglottic larynx, a part of the voice box above the vocal cord. The actual vocal folds are down here, subglottis, the trachea, and the bronchi going into the lungs. In trisomy 18, any of these areas can be affected. So professionally, what we do is we take this, we're able to make devices that are very specific. And so so I took that image, and I'm able to make a silicone mask that I can peel off and have bones underneath, and then use Snapchat filters and switch my face with the 3D pattern.
Disturbing.
Let's see if this will play.
You get a great speaker award for
Yeah. So we can do these kind of fun things. So a little bit of background on trisomy 18. About 1 in 6,000 live births. In 1996, the mean survival was reported as 3 days. In 2015, the 5-year survival was reported to be up to 12%. So we looked at the University of Michigan experience. To do this, we had an IRB-approved study. We used Data Direct, which is a special University of Michigan program that can go and identify anybody that has certain diagnoses. So we were able to pull anyone that had, the search terms that we used were the trisomy 18 and Edwards syndrome. And through this Data Direct, we were able to go and get the information on every kid with trisomy 18. And so we looked at this over the past 17 years. And so I was talking to Brad, and it's really been the last 10 years about that I've shifted to and had a greater portion of my practice with trisomy 18. So we found 40 patients at the University of Michigan that we followed at this point. Of these, 26 were females and 14 males, so about 2 to 1 females versus males. And as I look around the room, that seems about right here. So what was the survival for these children? We had 65% 1-year survival. Partial trisomy 18 was not statistically more likely to survive, and females were not statistically more likely to survive than males. So this is dramatically different than anything else that's reported. And I think the reason for this is aggressive airway intervention for these kids. And I saw John just kind of get shocked a little bit with that number. And it is. I told him there were some shocking things that I was going to show. So a little bit about breathing. This is Marcus Aurelius. He was a Roman emperor and also a philosopher. And for the Romans, the definition of being alive was whether or not you could breathe. So different societies have different concepts of what it means to be alive. For some, it's the heart stopping. For us now, it's brain waves ceasing. But for the Romans, it was breathing that was the key. And that is, I think, one of the key things, or the heart and breathing, to have survival for these kids with trisomy 18. So what is the function of the upper airway, and why do we need to be able to breathe to survive? So there are 3 portions for the upper airway that function. One is to move oxygen and carbon dioxide. The second is to protect against aspiration or food going down the windpipe. And the third is phonation, or being able to make sounds and to be able to talk. So these are the three things. And if we can't move oxygen, then we become hypoxic. That can be identified with a pulse oximeter. However, even if the pulse oximeter is normal, that doesn't mean things are okay. You can have the CO2 become elevated and run into a lot of problems from the CO2 becoming elevated. And I see a lot of parents nodding. This is a fun audience for me to talk to because I know I'm talking to parents, but it's almost like talking to knowledgeable medical providers here, where you're very familiar with these things. So here is a diagram of the child showing the situation here. Again, we have the tongue can cause a problem falling back. We have the supraglottis or epiglottis. We have the nasal cavity with the nasal throat or the palate can fall back. The chin can be too small to push all these structures back, and then the airway. So one of the concepts that's important is what is the difference between stridor and stertor, or different breathing sounds that kids make, and what does that mean? So with a normal child, when they sleep, they should be silent. We say sleeping like a baby, and when we say sleeping like a baby, we don't normally mean but as you know, and I see people pointing in the back here saying, that is, oh, maybe, is it he sleeps like that? Or so when you hear that sound, that's just called stertor. And when stertor is occurring, that normally means there's soft tissue somewhere that's collapsing in the back of the throat. And there are a variety of reasons that soft tissue can collapse, but that snoring sound is indicative of soft tissue collapse. Stridor is a more musical sound, like a sound. And stridor is indicative that something is vibrating very quickly, normally at the level of the voice box or the windpipe. And so that's one of the first things as an otolaryngologist that I'm listening for is when the child comes in, is what sounds are they making, and when are they making those sounds, and how much effort are they making to have those sounds occur. So we talk about retractions. Retractions is where you are breathing so hard that you see things sucking in. You'll see suction under the ribs. Suction, you'll see the ribs become more prominent with each breath. You'll see tissue coming in from above the thoracic cavity, all coming in to help someone breathe. So we're looking at retractions. Stridor, we want to know, is it just when they're awake, or just when they're asleep, when they're lying up, or sitting down? When do we hear the noises? High pitch is a high frequency, and so the higher the pitch, the more scary it is. So it's much more frightening than a lower, more musical sound. So airway obstruction in trisomy 18 appears to be the most common cause of death in the first year of life, and we talk about 8% cardiac mortality among children receiving intervention. So the most children with trisomy 18, but without airway obstruction, without significant cardiac disease, can live long term. If the airway obstruction and the cardiac disease are treated long term, survival appears to be an expectation rather than something that's an anomaly. And so it's aggressively dealing both with the cardiac disease and the airway disease. So how can we assess the airway? So this is direct laryngoscopy, bronchoscopy. And so there's different things that we'll typically do in the operating room from a diagnostic rather than a therapeutic side. So the first is something called sleep endoscopy. So with sleep endoscopy, we have the child go to the operating room and go to sleep in the operating room with medications. So it's the same medications that Michael Jackson used to go to sleep every night, but with the responsible anesthesiologist in the room and with the team that's able to do that. So sleep endoscopy, with that we take a fiber, we pass it fiber optic, to allow fiber optic visualization. We go through the nose and we're able to look at all these areas and see where the obstruction's coming from and get an idea. We can also test interventions where we'll use jaw thrust to bring the jaw forward, say, okay, how much of this problem, how much of the problem goes away with the jaw thrust? And we can also go and take a look down lower in the airway where we look at the trachea and all the way to the main stem bronchi, and this is where we'll diagnose malacia, particularly bronchomalacia, which appears to be underreported in the literature, but it's an important cause for airway problems. So now I'm going to be very specific about trisomy 18. Kids with trisomy 18 tend to be very difficult to intubate. And so we heard that from the talks before. The kids are difficult to intubate. So the average grade, so grade 1 is where it's very straightforward, where we'd expect even a medical student to be able to intubate somebody that's grade 1. Grade 2 is you expect somebody, a well-trained anesthesiologist, to be able to do it. Grade 3 is you really want to be at an academic medical center. And grade 4 is it's difficult even in the best of hands. So many of the kids with trisomy 18 are grade 4 airways. The average grade was 2.66, which means you're already beyond the capabilities of most residents that are ready to go into practice. And that's why our advice as a general rule, until the airway has been proven good, is to try to be at an academic medical center if any child is to receive general anesthesia for any reason. It is easy to underappreciate how bad the kids are. So we train residents at the University of Michigan, and I'll have people say, oh, I'm not expecting things to be hard here. And I'll say, this kid has trisomy 18. I would expect them to be hard. You need to be on your A game. You need to have everything in place for the most challenging case that you've ever had in your career so far. We will be around to back you up when you aren't able to identify it, even doing all those things. And so, this point here, for half of kids that we had, we needed to have specialized ENT instrumentation in order to go and intubate the airway. That's for half of all kids. A lot of that has to do with the small jaw that makes it harder to get to. There's improving equipment that anesthesiologists have where they're able to do better and better at a lot of places, but still having an experienced otolaryngologist that's used to dealing with the small mandible is critical for these children. Okay. So we looked at children at the University of Michigan of 40 kids and said, how did survival and airway interventions how are they associated with each other? So of neonates that died before 1 month of age with trisomy 18 at the University of Michigan, we had 6 kids that died in this situation. Only 1 had evaluation of the airway, and that was diagnostic with no intervention for the airway. Of kids that died between 1 and 3 months, 0 of 5 had any airway evaluation, and this includes 2 that had cardiac surgery without airway evaluation and then died afterwards. So now of kids that survived beyond 3 months, that's 26 out of 29 kids. So we're excluding these 11 that died, and so the rest, 26 out of 29, had airway intervention. Okay, so what kinds of things can we do to evaluate, or of the kids that live beyond that 3-month period, 26 out of 29 had airway intervention. So sleep studies. So one of the things that we can do that I find, yeah.
So when you say airway intervention, are you talking about everything? Are you talking about trace or like removing tonsils or adenoids? Or what are you saying?
Something.
So just something that you don't have specifics on like what something was.
I do have specifics. I do have specifics I'll talk about later. But it's, so I think the diagnostic evaluation can be very helpful in deciding what to do. And I'll go through in more detail about different things that we've done. Yeah.
Should we want our questions to be in? Because I had a question about anesthesia and I wanted to ask you.
Yeah, please, do go ahead and jump in.
Because Carson's committed to saying something, now she just started tracing the fall, and so I always demand that she get an experienced anesthesiologist, not an anesthesia resident, but an anesthesiologist with a scope prepared to intubate her when she needs to be intubated. And so is that reasonable for parents who haven't been in that situation to say, no, the PICU resident is not going to intubate my child, they have complicated airway? Because I think sometimes they don't believe us, they're like, oh,
Yeah, you're exactly right. It's easy to say, hey, this doesn't seem to, I'm experienced, I've intubated 5 kids before. And that's, yeah, it's a different, these are a different deal.
At University of Michigan, the anesthesiologist gave us a letter of critical airway. So that, like, just that phrase alone, if you say critical airway, but also gave us a letter that I almost tattooed on Pacific. Just so every time somebody was with her, they knew critical airway. And we did have a botched intubation where she has limited vocal cord, has one stuff, limited left vocal cord because they were shoving it in. So, I mean, the words are important to say critical airway.
it's reasonable to request.
We always make sure it's posted. We always make sure to have it posted above Lila's bed.
Yeah, we do for Carson, I just wanted to make that clear. You know what I mean, like the other things, that's okay to request.
Yeah, I think that's a, yeah.
I was just going to say, we're going to be having surgery on Monday for tonsils and adenoids removal for my son Alex's 2, his trisomy 18. What is the difference between a bronchoscopy and is it called a DICE?
Yeah, so DICE is a sleep endoscopy.
So what's the difference between that and bronchoscopy?
So DICE, or so DICE stands for drug-induced sleep endoscopy, and that's evaluation of the airway above the vocal folds. And so it does not go below the vocal folds, does not look at the trachea or bronchi.
So we've done 2 bronchoscopies, so maybe he's only doing DICE because he needs to do that,
So, I'm just gonna, this is my guess, it could be totally wrong. All the caveats that go with trying to go in and guess what somebody's doing without knowing the patient or the physician or anything about it. When I have a child that is not straightforward, that has sleep apnea, where it does not seem clear that the tonsils and adenoids are the problem, then I want to make sure that what I'm doing is going to be of benefit and that I'm not missing something completely. Particularly in trisomy 18, we won't just, I personally won't just do tonsillectomy and adenoidectomy like I would for a normal kid with sleep apnea. So if you take a look at all normal kids with sleep apnea, 90% cure rate just by taking out the tonsils and adenoids. For a variety of reasons, as an exclusive procedure, that's unlikely to work with trisomy 18. It's possible, but it's, and so that's a very responsible and thoughtful approach that's being used there. So again, we've got, we had the 11 kids that did not make it to 3 months of age, and so we kind of need to subtract 11 from this 40 here. But 19 of 40 children who had documented sleep apnea. Of those with documented sleep apnea, of those that had a sleep study, 4 out of 40 had a sleep study that did not show obstructive sleep apnea. So the vast majority of kids with trisomy 18, even in the absence of gross symptoms, will end up having sleep apnea. Sleep apnea, I'm going to get myself in a little hot water here, but I'm going to say this anyway. Sleep, as a parent of a child with trisomy 18, there needs to be decisions on when to intervene and when not to intervene. With a typical child that has mild obstructive sleep apnea, we will take out the tonsils and adenoids and expect a 90% cure rate and expect improvement in attention at school, maybe some sleepiness, some pretty mild symptoms. In a child that has trisomy 18, if there's mild sleep apnea, putting that child at risk to go and take out the tonsils and adenoids when there's no clear symptoms related to that sleep apnea is probably not a wise move. It depends on what that kid's symptoms are from it, but as a general rule, with a child that has mild to moderate sleep apnea and trisomy 18, I'm going to advise observation or a trial of CPAP and see if there's any clinical benefit that can be seen by addressing that mild sleep apnea. Now, there's a difference between that and severe sleep apnea, where the saturations are dropping into the 70s or 60s. And so you can have your pulse oximeter at home, where you measure. I found that it's a great thing that people have this notion that, oh, we need to get a pulse oximeter to watch our kid. And that can diagnose things like obstructive sleep apnea in a very imperfect way, and only most severe forms. But if a child has severe sleep apnea and is desaturated down into the 70s, then a pulse oximeter can give you an idea, and then a formal sleep study can give you how bad that sleep apnea actually is. DICE can let you know where the problem is, and then you can figure out what type of intervention to occur. So most of children with trisomy 18 will have sleep apnea. 90% of those with sleep apnea, it'll be severe, and 4 out of 23 that had a sleep study, so that's 16%, did not have sleep apnea at all. So it's not universal, but right now, my understanding is that sleep studies are part of the routine care for kids with Down syndrome, whether or not they have symptoms. And in my mind, the kids with trisomy 18 are well and above the levels of sleep apnea and the commonness of sleep apnea that is seen in trisomy 21. So this is an apnea-hypopnea index of the patients that were examined. And so we have some that are unknown where they have a diagnosis and using BiPAP, but we don't have documentation what it was. We've got some unclear data. But it ranged from a 3.1, so less than 10 is going to be relatively mild. So we have some 3.1, 9.5, 10.2. We also have 68, not 83. We have some very big numbers. What is yours?
Which one's fake?
Yeah, one of these is fake. So normal is less than 1. To put it in perspective. Okay. Treatments for obstructive sleep apnea. So the first treatment for obstructive sleep apnea that is a non-surgical treatment would be CPAP or BiPAP. That's where a mask is worn on the child's face or nose at night. The amount of pressure can be brought up or down as needed and with the sleep study being done at the same time to show that the sleep apnea is being treated. And so this can give you an idea what kind of changes occur with it and how things are. There are a number of other surgeries that we can do here. Adenotonsillectomy, that's the classic tonsillectomy and adenoidectomy, or removal of the tonsils and adenoids. Pharyngeal surgery, that's where the palate collapses back. The palate can be tightened or partially removed. And a lot of kids, I find it very helpful to be very aggressive in dealing with the palate. Mandibular distraction will help bring the tongue forward. So in general, somebody had asked me about what to do about the tongue falling back. In general, for kids with trisomy 18, you're better off bringing the jaw forward rather than trying to tie the tongue or do something to bring the tongue forward. But there's variability in that. And I ran into, just coming over here, I ran into a woman whose child had mandibular distraction. And the first case in trisomy 18 that I did of mandibular distraction was Faith. And I was like, there's a lot going on in Faith. But clearly the mandible is a big component. She's got stertor and obstruction. And we'll see if this has an effect or not. And it's not perfect, but it was a lot better than she was before.
She took her first steps after you did that.
So sleep can make a big difference, for these kids. Supraglottoplasty is, yeah.
So when you do your sleep endoscopy, do you get a sense of who might need a mandibular distraction at that point?
Yes, you can get a sense for that. You can. So if you see the tongue in the back of the throat in somebody with a small jaw, and you do jaw thrust and the tongue comes forward and doesn't continue to fall back, that's pretty clear-cut mandible problem. And in a lot of the kids, you can look and see how the mandible and the maxilla how close those come together. And some kids with trisomy, this to me is very interesting, that a lot of kids that have survived without airway intervention, their mandible will come up almost to the maxilla. And so they didn't need that distraction or that aggressiveness in dealing with the airway that a lot of kids with trisomy 18. So just like when you look around, some people, their jaw's like, they got a big underbite and just a gigantic jaw. Same thing with trisomy 18. There's some kids that have that without anything being done. And a lot of those kids will not need to have anything from an airway standpoint. Those kids seem to do the best of any of the kids. And you say, oh, Dr. Green likes to go and take care of the airway. And we were just talking about a patient where I said, hey, the jaw's good here. I'm not hearing any obstruction. Things look good. I don't want, and the mother's like, hey, I want a trach. I go, we don't need to do anything. Actually, everything's good here. Yes, it's common to have problems, but in this case, it does not appear to be an airway the classic type of airway obstruction that we see with trisomy 18. Tracheostomy bypasses everything that is above the tracheostomy. So anything with the supraglottis, palate, tongue, mandible, all those are bypassed with the tracheostomy. And so a tracheostomy can be done solving all these issues. Potentially you can give positive pressure with a ventilator and deal with the malacia. So the tracheostomy is kind of a quick answer, and then you can try to sort out afterwards what the problems are and potentially move towards decannulation. Okay, so what is CPAP? This is a boy that has a very small jaw. This is Treacher-Collins syndrome. I'm sure with John Perry, he's going to pick it up right away. No, this is not trisomy 18, correct? And so what we did here is we'll use a photographic capture system where we're able to, so when you have a small jaw, a lot of times getting the mask to fit right is very difficult with trisomy 18 kids. And I see a lot of nods here where, yes, we tried CPAP, it didn't work out well. It's the jaw that causes the problem. So one of the things that we're working on is making masks that are custom to the small jaw. Now this is very beginning trial that we're in right now, we're dealing with kids that are able to give us very good feedback, like, oh, it's too tight or not too tight. And so for kids with trisomy 18, in general, they're not, it's not going to work well for them where we're at now. But we hope to be able to get to that point. And so we're able, in this case, is a child with Treacher Collins, whose mother was waking up every 15 minutes all night long to adjust the mask. And by having a custom mask, he was able to sleep through the night. Now, again, on the way here, I was talking to a mom that was like, yes, I was waking up every 15 minutes to go and make sure my baby was breathing. You know what that's like. And so having some type of intervention to help these kids is important. So we had the computer design, and so here is the image of the child, virtual design of the mask. We make a mold. We go to a 3D printer, print the mold out, cast it in silicone, and we are able to make a custom mask that their child is able to use. Yeah. Okay. So these are the diagnosis, the upper airway diagnoses that were made that had an effect in the kids that we looked at. So that's the 29 kids that made it over 3 months that had some type of airway intervention. So bronchomalacia was seen in a very high percentage of those kids. And that's something that's normally not noted. And bronchomalacia is where the windpipe beyond the trachea will collapse. And when that happens, then when there's swelling, breathing becomes a lot more difficult. And so bronchomalacia with swelling becoming more difficult, when does that happen? That happens with a cold. And any obstruction will get worse with a cold. And so a lot of kids, even when their airway is dealt with or they have a tracheostomy, when they get a cold, they'll really deteriorate. And a lot of that has to do with bronchomalacia or collapse of the windpipe. And so you put somebody on a positive pressure with a ventilator, that will deal with that. And so there are a number of kids that when they get a cold, they need to come in, get some positive pressure support, BiPAP, or be on a ventilator for a week or two. When their cold's done, then they're able to go back home. And that's my interpretation of why that happens. Micronaphia, or the small jaw, is very common. Endotonsillar hypertrophy, tracheomalacia, which is a windpipe in addition to the bronchi. Retronaphia is a retronaphia and micronaphia. These should be one thing, because they're both the jaw being too small. This one just means back. Glossoptosis is the tongue falling back into the throat. Several of these will be associated with the micronaphia as well. Then there are rare causes: subglottic stenosis, laryngomalacia, choanal stenosis, cleft lip and palate, TE fistula, vocal cord paralysis. There's some other rare things that we see less commonly, but the key thing with these rare things is that you can see airway problems anywhere in the line, from where air goes into the nose or mouth all the way to where it makes it to the lungs. Okay. Intervention. So this is a tracheotomy, and it's the most definitive one. Yeah, this is one of my. I like this picture. I got it from it's in I think an Italian description of what a tracheotomy was like. So in these days, and when it was first discovered, they didn't use any general anesthetic. Yeah. Alexander the Great saved somebody with a sword. We're not using swords, and we are using general anesthetic. So we're a lot better than we used to be. Okay. So tracheotomy. 12 out of 40 children required a tracheotomy, and of those 12, 10 out of 12, it was within the first 16 weeks of life. So it's very early on that a tracheotomy can make a gigantic difference. And of those, 2 out of 12 were decannulated, but 1 required the tracheostomy to be replaced. So our decannulation rate or eventual removal after a tracheostomy has been done is a lot lower than what I'd like it to be. And so this is something we need to look at more. My general, the way that I'm thinking now is to let the kids get older and thrive and have a good airway so they can do as much as they can from a physical standpoint. There aren't airway limitations to what they can do as far as rehab goes. And then later on we'll head towards getting the trach out. But that's, frankly, it's a matter of parental preference on what they like to do. These are the surgical procedures. So we talked about where the sites of obstruction were. These are the different procedures that were done. So the diagnostic procedures, 33 laryngoscopies and bronchoscopies. Tubes were the second most common ENT procedure. Trachs, tonsillectomy and adenoidectomy, sleep endoscopy, nasal endoscopy. Nasal endoscopy is really sleep endoscopy here. Examination under anesthesia, mandibular distraction, and some palatal work as well. Okay. So I want to go and shift from the airway, talk a little bit about ears. And so this is some work that we've been doing where a child's born with microtia. We will take an image of the opposite ear, reflect that image. We can then make, just like we did before, we'll make a 3D printed construct of holes for stem cells. We'll take peripheral stem cells impregnated into the 3D printed scaffold, and then we can implant these into the pigs. So we have pigs with human ears. This was early. We now have very good looking ears, and we're headed toward, right now we're trying to sort out the FDA approval for using this for microtia. So these are some of the fun things that we're doing here. And then this is just a picture of the inner ear and middle ear of a child. And this is a 3D printer. This is a malleus here, and this is a dime for comparison. But you can see the kind of resolution that we can get as far as imaging with 3D printing. Okay, so hearing loss.
How about doing the imaging? Like what mode are you using?
CT scan? Yeah. So hearing loss, 13 out of 14 patients with trisomy 18 had hearing loss. 5 out of 13, it was a nerve type hearing loss. 3 out of 13 mixed, 3 out of 13 conductive, and 2 out of 13 unspecified. These numbers I need to look at a lot more, and this is like a separate paper. One of the main problems that we have is the great deal of atresia of the canal, or how small the canals are in these kids. So in contrast to Down syndrome, where otitis media is a very common thing, in trisomy 18, it appears that otitis media is no more frequent than the regular population, except for the kids with trisomy 18 that have a cleft palate. So if we exclude that group, then we don't see a lot of middle ear disease. However, when you do your audiometry, the narrow ear canal and the cerumen impaction and the difficulty in getting the examination can make that a very difficult diagnosis to make. So here are the hearing diagnoses that have been made. So the ear, very stenotic, external canals, 1 to 2 millimeters. Frequently, wax will get caught in these, and it's very difficult to remove in the office when they're this small. And so often, if a child's going to get an anesthetic for any reason, we'll try to clear out the ears at the same time. Wax trapped medial to a stenosis that can't make its way out of a canal will eventually start to erode the canal and erode into the ear bones and can cause permanent hearing loss. So it's important to have that addressed. There are canal widening procedures that can be done. The other thing that we find is a typical hearing aid that goes in the canal will stop. Yeah.
Sorry, I'm jumping back, but you mentioned the earwax being in there. So if you're not having any procedures done or anything like that to combine it with, like how often would you say that that should be done?
It's what does the exam look like?
Okay.
And if you're seeing wax, if they're unable to see the eardrum because of wax, then that's something that in my mind should be addressed in some way. And it doesn't need to be frequent. And it could be every couple of years. Yeah.
Jumping even one step further back with the middle ear disease, where you were talking like with the fluid in the ear and how we don't see that as much with trisomy 18, but we would see it more with Down syndrome. If someone is having a procedure already, like having a surgery, something that we did, we were kind of on the fence about whether or not to get tubes. I actually spoke with you on the phone about this prior to it to tell our ENT what you just said, which is like it's more common with Down syndrome than it is with trisomy 18. We got like a flat panogram, but it was like, is it because of fluid in the ear or is not? And so, is it reasonable to have the ENT do a microtomy if they're going to be like having a procedure for something else already to see if there's fluid that comes out, and if fluid does come out, is it reasonable to assume it's probably always in there and the tube should be placed?
I think that's a very good approach, depending on how bad the canal is. And so with a very narrow canal with tubes in the ear, sometimes they can make things worse rather than better.
His did come out, thank goodness, but we were nervous about that.
Yeah, it can be a problem. So when they're asleep, to go and take a look at the ear, clean the wax out, and see if there's fluid in the middle ear space, and then place a tube. If there is, that's an appropriate, in my mind, that's an appropriate consideration. We wouldn't normally do that in a typical child, but here we want the hearing to be good. We want to make sure that the sound's as good as it can be. And we'll normally also get a hearing test at the same time, get an ABR to get definitive hearing results. Bone conduction devices. We will use bone conduction devices with a lot of kids so that there's nothing that's in the canal and it will bypass any cerumen that's in the canal or narrowing. So the bone conduction devices seem to be very helpful for a lot of these kids. So we had 10 out of 40 that had tympanostomy tubes placed, and so supposed cleft palate being the most important. And so this is just a picture of that you can sometimes get an MRI that shows the cleft before birth. And this is a child with a cleft. And we before the child was born, we made an image of what they look like. Okay. Pharyngeal obstruction, this is back to the throat. So tongue-based prolapse, palatal prolapse, and micronaphthia. And then we talked about the trach adenotonsillectomy, mandibular distraction, and the other problems. So hearing in trisomy 18, many of the children will have normal hearing if you can get the earwax taken care of, or close to normal hearing. And my own experience is that most kids with trisomy 18, as they get older, have great appreciation for music. Many will dance or strum along to the music in a way that they won't to any other thing. And I think that's very good in a lot of ways for them to do that.
Can I go back to the ears? I saw that you mentioned, maybe to touch on it, the ear canal widening. Like, is there, I know like with a cochlear implant, they don't leave it until they're 5. Is there like a typical standard for that, or?
Yeah, so I'd wait till a child's 5-ish or still having a lot of trouble with wax getting caught, and there's no way to remove that wax without going to the operating room. And particularly depending on how dangerous how difficult the airway is, doing something to make it easier to remove the wax is a good consideration.